The Centers for Disease Control has just confirmed that
the most important point, almost everyone who might be exposed can get antibiotics quickly, limiting potential damage.
Good afternoon, everybody. Welcome to the Alabama Public Health Training Network. It's good to have all of you with us today all across the country. Some 35 states have enrolled and joined us today for our program and our lecture. We want to give you a couple of quick housekeeping notes before we continue with the program and introduce our speaker. There is an evaluation form available on our website. We hope you'll take a moment and go to the website. We'll show you the graphic in just a moment where you can actually go in and do the evaluation form on today's program. Also, anytime during the program, if you have a question or comment, please feel free to call our 800 number and ask our speaker any questions, and we always allow plenty of time at the end of the program. We hope you'll participate, ask the questions that pop in your mind, and we get a general discussion going on today's topic. Do we have the graphic ready for the evaluation form? If we do, I want to show you our website where you can go and register, not register, but fill out an evaluation form right online. You go to the website, www.adph.org/ALPHTN, and then click on the evaluation form for 12/2/2003. We hope you'll take a moment after today's program. We'd really like to hear from you and make sure we're meeting your needs in this lecture series. Very pleased to introduce our guest today in the studio. Dr. Michael Metz is Professor of Epidemiology and International Health at the School of Public Health at the University of Alabama, Birmingham. He is also co-principal investigator of the South Central Center for Health Preparedness. Dr. Metz, good to have you back in the studio today.
Thank you, Mac. It's good to be here. I'd like to welcome everyone as well to this preparedness update, which, as Mac indicated, is a program of the South Central Center for Public Health Preparedness. And this is a joint initiative of the UAB School of Public Health and the Tulane School of Public Health and Tropical Medicine. This program is being co-sponsored by the Alabama Department of Public Health. In considering the needs for effective disaster preparedness and response, one area that's often been given less attention are the mental health implications of such events. Our speaker today, Dr. Neil Boris, will discuss common post-disaster problems such as acute stress disorder and post-traumatic stress disorder, as well as approaches for dealing with those problems. Dr. Boris is a graduate of Tufts University, where he received his MD degree. He subsequently did a combined residency in pediatrics, adult psychiatry, and child psychiatry at Brown University. He's currently Assistant Professor of Community Health Sciences at the Tulane School of Public Health and Co-Director of Child Psychiatry Consultation Service for Pediatric Wards and Intensive Care at Tulane Medical Center and Hospital. The title of his presentation is Evidence-Based Approaches for Post-Disaster Mental Health Disorders. Dr. Boris, welcome.
Thank you, Dr. Metz. It's really a pleasure to be here, and thank you, Mac. Indeed, questions are always encouraged. I look forward to getting some questions from out among the 35 states. I'm going to talk today about bioterrorism and mental health issues and response strategies. And I need first to thank two of my students, Rohini Singh, who's a master's candidate, and Alan O., who's in the preventive medicine residency program at Tulane, for assisting me in gathering some of the data for this talk today. It's really a story of science and emotion when you begin to think about bioterrorism and its impact on people's mental health. There's much to learn in this area, but there's much we already know. And today we're going to review data on post-traumatic syndromes, review data on immediate response strategies for prevention of those syndromes, present the rationale for a screen and track response strategy, and then touch on, a little lagniappe at the end, some of the social psychology of non-clinical post-disaster responses. It's an important area for all of us, and I'm going to read first a quote from the National Center on PTSD. This is a fact sheet that was put out shortly after September 11th, and it goes as follows. The impact of this magnitude of terroristic violence will affect people at all levels of involvement: victims, bereaved family members, friends, rescue workers, emergency medical and mental health care providers, witnesses to the event, volunteers, members of the media, members of the community, the state, the nation, and the world. Terrorism erodes a sense of security and safety at both the individual and community level. It can challenge the natural need of humans for the world to be predictable, orderly, and controllable. Those are pretty powerful words, and I think at times, again, the science and emotion intersect in this area in interesting ways. So when we think about September 11th, we look at community surveys, indeed, there was significant psychological distress expressed by many people, and many called for widespread expansion of mental health services. In fact, the government put forward $100 million to FEMA and the Center for Mental Health Services for post-disaster mental health response. Now, interestingly enough, if you look at the data with regard to the legacy of September 11th, there's some interesting findings. And here's a quote from a recent article in the American Journal of Psychiatry as follows. There have now been a number of studies, of which ours is only one, that have shown that, in fact, the increase in the use of mental health services and of medications was far less than previously reported and did not last very long. Now, it's never a good idea to start off your talk saying there's no need to give a talk, but indeed, when we think about mental health responses, to understand what typical responses may be, what we need to screen and track for across time, and whether we can predict that large portions of the population will suffer from mental health debilitating conditions or not. Typically not. So when we look at what happened with regard to September 11th, we find for sure that surveys suggest that fear, anxiety, re-experiencing, and hyperarousal were common and are known to be common after a major traumatic event, though generally short-lived. We also know that communities banded together. It was really striking to see, providing support, people who were vulnerable or indeed targeted, and that was impressive all the way around. So where was all the psychopathology? Again, fear is real. The issue of traumatic events is not one to be lightly talked about, but the capacity to endure is great. And resilience, in general, rules in this area. People are affected, but few permanently. Now, it is difficult when you look at the data to rule out under-recognition, so that the quote from the American Journal of Psychiatry does indeed tell us that most studies following September 11th have not found major ongoing psychiatric symptomatology in large portions of the population. Now, there may be portions of the population who are not well studied in those surveys. So let's talk about what we may expect in terms of the nosology and in terms of our understanding from the psychiatric perspective of responses to acute traumatic events. And we'll begin looking at acute stress disorder. Acute stress disorder is an important diagnostic entity, and it's marked by dissociation or numbing, brief disorientation, re-experiencing symptoms such as flashbacks, intrusive thoughts and images, and then avoidance of stimuli related to the trauma. Often, people in acute stress disorder situations will describe high anxiety, physiological hyperarousal, the surging heart rate, sweaty palms, etc., that most people are familiar with. Now, this problem lasts typically, in the nosology, is listed between 2 days and 4 weeks. And there is some question as to whether it deserves the phrase disorder, or whether, in fact, this is a normative response, because Indeed, follow-up studies of those afflicted with acute stress disorder suggest that most cases get better. So our nervous systems have clearly been honed by experience and evolution, and many of these acute symptoms are protective response systems built in to serve us in times of danger. When you think about assessment of acute stress disorder and what are there out there in terms of assessment tools, in fact, this is a new area, one where there are new publications coming out all the time, and there are indeed interviews, scales, and questionnaires available for assessing acute stress disorder, many of them now well regarded. What we consider is that when the acute stress is through, and that 4-week period, which has not been worked out well empirically, but which exists in the nosology, after 4 weeks' time, if symptoms persist, we consider the diagnosis of post-traumatic stress disorder. Now, post-traumatic stress disorder is something that's been well studied over many decades, particularly in war veterans. If you look at the prevalence of this disorder in community samples, you'll find that it's fairly uncommon. Adults ranging from 1 to 2.6%. Young adults appear to be more often impacted, with ranges in studies of young adults 6 to 9%. So the best longitudinal study in the U.S., the National Comorbidity Study, has a lifetime prevalence of about 7 to 8%. Now, of course, this data depends on sample used, the method of assessment, developmental risk, and you have to remember that for PTSD to occur, you have to have had a life-threatening trauma. And that's a perception. It's difficult to define what life-threatening traumas are, in fact, and certainly as you got away from New York and Washington in September 11th, question about what was life-threatening outside those areas is one of some consideration. Still, we need to be clear, post-traumatic stress disorder is a serious condition and may in fact be quite chronic in nature. Again, 3 core components, 3 main things to remember: the triad of symptoms, that is re-experiencing the event, flashbacks, nightmares, etc., numbing of responsiveness and avoidance behavior, and then heightened arousal. So the rapid heart rate at loud sounds, etc., as one good and classic example. The onset of symptoms rarely exceeds 10 months after the event. So that in the index of a terrorist event, in those most closely impacted, you would expect to see symptoms beginning early after exposure to the event. And the duration of symptoms must be more than 3 months to make the diagnosis. Now, for those of you interested in neurobiology, and I know, Mac, you're one of those people, right? A world interest in neurobiology. I'm going to give you one slide, and one slide only, about the biology of PTSD, because it gets fairly complicated. But there have been a lot of studies of both the stress hormone response and the impact on the brain in this condition. And one thing must remember is that our autonomic nervous system, that is the nervous system that controls heart rate and breathing rate, etc., is clearly impacted in acute and post-traumatic stress disorder. And those impacts really roll back to impact our brains. So that when we look at things like corticotropin releasing factor, MAC, again, one of your favorites, those concentrations are shifted in people with PTSD. There's a depletion of particular neurotransmitters in the central nervous system, and even reduction in actual tissue in the volume of particular brain tissue areas. PTSD is a serious and debilitating condition for many. And even in the axis of peripheral stress hormones and how they influence centrally the brain, we see lots of different findings across many studies of post-traumatic stress disorder. A serious condition, a physiological, biological condition, and one that is long-lasting in many individuals. Okay, that concludes, Mac. That's it for the neurobiology. We have covered this area in one slide or less, and of course there are volumes of data out there in this evolving area. But I want to talk about what PTSD itself, again, the condition we would be most interested in tracking post-terrorist event is PTSD, and that's in part because it's chronic, in part because it's physiological and impacts the brain, and also in part because it's associated with other significant comorbid conditions. So when we look at the data on PTSD and comorbidity, we see, first of all, that those with post-traumatic stress disorder are much more likely also to suffer from major depression over time. And here I've put the hazard ratios, pulling together the literature. These are many different studies that inform us here. Alcohol abuse, common as well in folks with PTSD. So too drug abuse, that is illicit drugs other than alcohol. And then a series of what we call somatic symptoms, that is headaches, abdominal pain, chest pain, etc. So that it is very common for people with chronic post-traumatic stress to present to the emergency room, etc., with physical symptoms that don't have an underlying known other biological reason for existing. And it's useful to remember these comorbid conditions. So here we have in PTSD something that we might consider to be a significant public health problem. And clearly I'm here in part, as Dr. Metz notes, because sometimes we forget about the mental health impacts of disasters, and they can be, in fact, rather debilitating. So when we put this in line, that is PTSD, as a public health problem in the spectrum of public health problems, we can analyze it as follows. So first of all, clearly it affects only a small percent of the population. Again, the lifetime prevalence in the best studies in the states, 8% thereabouts. Those who experience life-threatening trauma, of course, are the ones who can be diagnosed with the disorder, but it is clear that the majority of people experiencing a life-threatening trauma recover without ongoing symptoms. So, in some ways you could say, it's not that big of a problem. On the other hand, it's very significantly associated with morbidity and, in some cases, mortality. So that the combination, for instance, of PTSD, substance abuse, and depression predicts suicide, and so you have a problem that, bound with other problems, can be very serious indeed. We know it affects young people, and in fact may be more likely to affect young people. At least some of the data suggests so. And I even have a colleague at Tulane who studies PTSD in preschool children and younger. And there is no question that this condition can be identified even in those young groups. It's often chronic, that is to say, the very nature of the disease as it begins to impact the brain biology is chronic. And as far as the best studies tell us, it's relatively undertreated. So we'll talk about treatment at some point along the way here, but the general picture is that it's undertreated overall. So we've got ourselves something that indeed is a public health problem and one we must consider in bioterrorism preparedness. So let's think a bit about how either to prevent post-traumatic psychopathology or to move forward in at least screening and tracking. Now, when we think about preventing post-traumatic psychopathology, first thing we remember is we're only going to be needing, since it only impacts a minority of those who even develop acute distress disorder, to focus on a subsegment of the population. Most people recover without professional assistance. That's a beautiful thing. Not a lot of resources necessary. So the question becomes, when might we intervene? What sort of intervention works? And for whom would we put our interventions together? And that's what I want to get to next as we consider this problem. Now, the first intervention, and these interventions go back quite a ways in the literature, is psychological debriefing. I have much to say about this area. It's fascinating because, on the one hand, the first thought most of us have is that we need to go assist people who are exposed to life-threatening trauma and help them through it. And so psychological debriefing has a long history, and in particular in World War I, soldiers were encouraged to tell their stories. And in fact, the scientific study of psychological debriefing began really around this time. As we move forward through the decades, there was a lot of interest in assisting emergency response personnel with their own reactions to assisting others, sort of secondary trauma, as it were. And Mitchell developed critical incidents stress debriefing, in part for particularly working with emergency response personnel. The question has always been whether what most people in popular psychology would call venting, whether venting to others actually attenuates early symptom expression. And I think at this point the data would suggest it does not. In fact, the data would suggest that this practice may be harmful to people. And that's an interesting thing. We'll talk more about it. But let me first say that when you look at critical incident stress debriefing, those who are trained in this area are trained to think about essentially 7 phases of engagement with people who've experienced trauma. So the first is to introduce themselves, and then to ask the person what happened. Tell us about your experiences, and what did you think about what happened? Furthermore, those who are qualified in this area are asked to ask the people they work with how they reacted to the traumatic experience, and in fact, to get them to describe their stress reaction. Now, what follows is an individual or sometimes in group debriefing, wherein the stress reaction is normalized. Oh yes, that surging heart rate you feel, those nightmares you've had, those are common. Many people experience them. It's okay. And then a sort of disengagement phase wherein questions are answered and referrals are made as needed. Sounds very logical, sounds very reasonable, and in fact has even burgeoned into a sort of a cottage industry wherein there are many who do critical incident stress management, so they take debriefing and work it into management of stress, wherein there's ongoing intervention with folks. Everything from preparedness training for interveners to individual crisis support, demobilization, diffusing, and family support and referral mechanisms, so that we have critical incident stress debriefing and then critical incident stress management, sort of an evolution of this approach. As I mentioned already, the data with regard to critical incident stress debriefing is rather damning. That is to say, meta-analyses of randomized controlled trials clearly show that critical incident stress debriefing is ineffective And in some instances, at least in some studies, and the second study I have listed on this slide, the Van Emmerich study, suggests that it may be harmful. So herein, in the Van Emmerich study, they used a single session of debriefing, again randomizing people who experienced traumatic events to debriefing and non-debriefing groups, used a single session after a traumatic event, and found that those who received the intervention were more likely to go on to have symptoms of PTSD than those who did not. That is to say that not only was the impact of this non-helpful, but perhaps was negative. Now, we will certainly ask ourselves, well, now why does critical incident stress debriefing lack efficacy? I mean, a very important question. What's going on here? It sounds logical, it's intuitive, it's caring, and it may be something that we would otherwise think should be invested in. Well, probably what happens here, though people have not studied the process, is that awareness of your normal stress response, and even with education, the pathologizing of these stress reactions is not helpful to people. And in particular, by working through with people their memories, what happened to them, how they experienced the traumatic event, we in effect give them a re-experiencing of the event. And as best we understand the biological cascade of post-traumatic stress disorder, that continuing to re-experience the surge in the autonomic nervous system that happens is effectively kindling further symptomatology. We trigger memories, and we, in effect, can make people worse. We also may interfere with natural social supports by coming in from the outside with our team of interveners. We are potentially taking some of the community approach away from the community, and that's something that we struggle with in public health sometimes in different types of interventions as well. So, the first message from my talk today is that though intuitively useful, critical incident stress debriefing is ineffective and may in fact be harmful and should be placed aside in terms of treatment or prevention options. And I'm not the only one saying this. There are, as you will see, a number of reviews that conclude this as well. So, what about talking about trauma? What about how we deal with this? And certainly, when we look at studies of people's typical responses, we find that they alternate between avoiding thinking about what's happened and processing it. And really, in fact, if you look at naturalistic study of large populations' response to a traumatic event, only about 10% of folks actively seek help. Most individuals essentially create their own conditions to facilitate emotional processing. And though those of us in mental health are really good at what we do, pushing people to join our intervention after a trauma is contraindicated, at least when we look at critical incident stress debriefing. So, is the answer then to do nothing? That would be the first possible way to go about this. Certainly, in the acute aftermath of major events, probably less is more. On the other hand, given that we have a public health problem in PTSD that is significant and can be debilitating, we want to think about both tracking people who may be symptomatic and deciding when to intervene and how. So we'll go forward on that idea from here on out and use what I think people have called the screen, support, and track method, which is to say that what we do is use available screens to identify those with early symptoms in the acute stress disorder category. Now, are the screens sensitive and specific enough in large-scale studies? That's unclear at this time. On the other hand, screening is very unlikely to be harmful so long as in doing the screening we aren't going through the same debriefing process that I just talked about. Debriefing appears both not to work and in some cases to be harmful. And then tracking. This, of course, is a challenge for us in population-based work, but tracking is key. PTSD is debilitating, it's costly, it's treatable, and we need to screen those at highest risk and track them over time if we are to be effective. Now, in so doing, we'll want to know of those who are exposed to a major traumatic event and go on to get PTSD. What do we hang our hats on? What does the data tell us are the most important predictors? And I've put together a slide here. It's packed with quite a bit of information. It's from a number of different sources, but it will look at PTSD across studies and its primary predictors. And if we go to that slide, we'll see that there's a greater, first of all, of course, exposure to traumatic events, repeated exposure to traumatic events predicts PTSD. There's no surprise there. The more trauma you've experienced, the more likely you are to get PTSD. So too, if you've had prior psychological or psychiatric problems, and you can see that these effect sizes are not large, but are still significant. Psychopathology in the family, we understand about the genetics of anxiety disorders well now, and we know that those with a family history of especially mood and anxiety problems are much more likely to suffer from PTSD after a traumatic event. Now, the next things bump up in terms of their effect size across these studies. So they're even more powerful than these first three. The first is perceived life threat. So herein, how the person perceives the experience, how threatened they felt personally by the event, is a very powerful predictor of their later symptoms. How much support they have around them, in particular social support, networks, family, etc., very important. And then the final piece, which we'll talk a little bit more about, is something called peritraumatic dissociation. And this is a clinical term. It's an important one to understand. You look here at an effect size of 0.35, which is quite large. Peritraumatic dissociation predicts post-traumatic stress disorder better than any other indicator. Now, acute stress disorder has not been well studied. That is, how many people with acute stress go on to have PTSD. But woven within acute stress disorder symptoms are a lot of these predictors, and that's why I went over what acute stress disorder is. It's clearly a precursor. So what about this peritraumatic dissociation? Fancy words. Every time we get the hyphenation with more than 5 letters here, Mac, we're getting into the fancy word territory again. Not as bad as the neurobiology, but getting there. Peritraumatic dissociation refers to alterations in the experience of time, place, and person during and immediately after a trauma exposure. As when you speak with people, they will tell you that they had an unreal sense of time, they weren't sure where they were and what was going on around them, they lost track of their thinking, etc. This descriptive syndrome is important for us to understand, and we know that as it relates to PTSD, it's mediated by degree of fear about death and a feeling of losing control. So that those individuals who report that they experienced around the time of the traumatic event an alteration in experience of time, place, and person, and great fear about dying or losing control are in fact those that we would want to follow. Now, one of the troubles with screening for PTSD is that those at highest risk, and remember people with prior psychological problems, with family history, those who really perceived that they were at great threat of dying, may be very difficult to engage in health screening and in tracking. So after a traumatic event, even avoiding help seeking is not uncommon. People feel like they're going to lose control if they talk with anyone about what's going on with them, and that by getting screened and seeing a professional, they'll find out that they're psychologically injured. And so one of the troubles with PTSD screening is that there is some risk aversion in terms of the population coming in for screening. On the other hand, when you look at studies that have done good screening and used instruments to predict who goes on to get PTSD, there's useful screens out there. So that, for instance, a total of 40 questions combined from the Peritraumatic Dissociative Experiences Questionnaire, which is a self-report questionnaire, and the Stanford Acute Stress Disorder Questionnaire. High scores on both of these self-report instruments within 24 hours of exposure predicted 33% of the variance in PTSD symptoms 3 months later. So at the time of a traumatic event, you can screen and predict 33% of the variance in PTSD symptoms. Now, 33% is not great. On the other hand, again, it's a debilitating and significant condition, and there is at least some hope that screening and tracking will do well. Now, I think it's this hope that has gotten the CDC on board, and they have developed a rapid assessment instrumentation that I hope many of you are already aware of. A mental health intake form is available online. It's designed to be completed by clerical staff at mental health or crisis clinics, defined by explanatory notes so that health departments can train and dispatch workers effectively and efficiently, and it doesn't require software for data entry. So in that way, this rapid assessment instrumentation is a terrific move forward, and I have here the website where you can download the mental health survey instrument. Again, a useful thing for those who are going to be involved in following traumatized populations. Now, if we say that our job then is to screen and track and not to do psychological debriefing, and we want to know what are survivors' needs in the aftermath of trauma. What does help if critical incident stress debriefing does not? What are the best approaches? And the data, though limited here, would suggest that, first of all, first thing is to be practical. That is to say, shelter, financial support, getting families enough food and shelter is the first and most important need. And in fact, mobilizing to do this, which is costly and necessary, is much better use of resources than mobilizing to get stress debriefing teams together. Whether the individual wants to talk or not about their experiences is something that they can decide. And so taking the survivor's lead, listening without probing, is in fact the most indicated approach for those of you on the front lines in dealing with people who've been traumatized. And again, asking them to tell their story, to repeat to you what their feelings were and reactions were, may in fact make them worse. Well, what will make them better? If they go on to develop PTSD, it's also important that we be aware of effective intervention strategies. So if our approach is going to be to screen and track and then intervene at the time when people have significant symptomatology, given that we don't have, at this point, a good prevention approach, then we need to know about what treatments for PTSD work. And so I'm going to delve into that a little bit now. Though many of you may not be treatment providers, knowing that treatment works and understanding the basics of treatment approaches is probably important and helpful. So the first approach is the medication approach. As you know, pharmacology has advanced tremendously, and in PTSD there are now a few randomized trials that are available to look at symptom reduction in those treated with various types of medications. Now, again, these are a few trials. They're certainly promising. It's clear that the selective serotonin reuptake inhibitors, or SSRIs, as a group and individually, as you see listed on this slide, do reduce symptoms of PTSD in those who are randomized to receive them. That's important. Medications can be very effective, and understanding that is important for all of us on the front line. The medications are certainly not the only approach. They are not even necessarily the first approach, although they can be, for large-scale disasters, really an important thing to remember. Because the other approaches, including cognitive behavioral therapy, which is clearly the best studied therapeutic approach for PTSD, work well but require a lot of resources. And in cognitive behavioral therapy, just briefly as an overview, the therapist will work to identify dysfunctional thoughts, actively challenge them with the individual or groups of individuals, and work to help the individual or groups of individuals replace them with realistic beliefs and functional behaviors. So those who are avoiding memories or areas wherein they were traumatized can be helped to see that re-traumatization is unlikely, that safety is there for them, and that they don't need to avoid working in order to avoid feeling at risk. So really you're looking at maladaptive thoughts, and this is very common in people with PTSD, and you're focusing on safety, on trust, on giving people the sense that they have power over their environment, and often on restoring self-esteem and intimacy. Intimacy in relationships is difficult for people suffering with very high levels of anxiety. Cognitive behavioral therapy has been studied well. There's good evidence for its efficacy, but again, it's a costly intervention, particularly in that it's most impactful in individual work. It's clearly more effective than other supportive kinds of therapy, but the delivery is key, and the dose is variable. Some people need a good number of sessions, talking about many over months, and the people who provide this intervention often have to be trained highly. So, cognitive behavioral therapy and medications are the two staples of intervention for PTSD. Both are effective, both are relatively high cost but high yield, and they're worth remembering. Now, there are a couple of larger issues that impact treatment of PTSD, and I think they're important for us as a group of public health professionals to remember. And certainly stigma is a serious problem, so that people are not often wanting to talk about how debilitating their mental health symptoms are. The World Health Organization has highlighted stigma as a major problem worldwide. And so our jobs as public health professionals are to assist in programs that diminish stigma so that people will come forward for intervention. And I think we need to use social marketing approaches with regard to this. I think this is important on a broader scale. and that the lack of parity for mental health treatment that we have right now in this country is one issue that exacerbates the stigma problem. So there are larger scale issues that make post-traumatic stress and other significant mental health conditions really difficult to combat on the population level. On the other hand, there are effective interventions, and we can screen and follow. So for this portion of the talk, and this is most of what I wanted to present on, I'm going to come forward with some conclusions. And then we'll talk a little bit about some larger social psychology data about terrorism and large-scale responses. So, in conclusion, really, first do no harm, and the Hippocratic oath that those of us who are physicians have to take is something that we often forget about. Critical incident stress debriefing has a natural, intuitive sense to it. It's a natural inclination of those of us who want to help. In fact, it's been, in some areas, listed as a standard of care, so that organizations in fear of lawsuits feel like they need to do something. And it's certainly politically expedient to do something in post-trauma situations. However, doing no harm needs to be our first thought. If we do no harm, and if we are wise about the significance of these disorders, screening, tracking, and treating is in fact clearly indicated. And we need to really snuff out prolonged stress response because the resulting morbidity is significant. Now, we must remember that good tracking can be undone by stigma, that as public health professionals we'll need to reach the most hard-to-reach populations. And I think clearly we need more research in this area if we are to be effective. There is lots going on. There will be more to follow. I think the research on September 11th and its legacy is interesting in that some of the fears about widespread mental health problems were not realized, while still the same high-risk groups of people did go on to have post-traumatic stress. Now, I've put some references together in this handout for those who are interested. Again, there's much new data, and in fact, meta-analyses of multiple studies now available, both on PTSD, on critical incident stress debriefing, and the like. And so those will be available to you online. I find these references most interesting. I thought I would close with a little lagniappe today, to take us in a slightly different direction, and talk a little bit about social psychology and something called terror management theory. And I'll say this, that this theory has been around for quite some time. It probably predates this bioterrorism preparedness grant by a few decades. But people have considered human behavior in a terrorism context through the lens of sort of a theory of how do social groups respond to life-threatening events. How do we as human beings, how should we expect the range of responses to be, and what kinds of social changes following large-scale terrorist events might we expect to see? This is a nascent science. It's one where there's lots of interesting new data, but of course wide-scale studies are limited. I'll tell you about terror management theory because I think it's interesting, and I'll tell you that the first thing about it is there are a couple of assumptions underlying it. And the first is that self-preservation and reproduction are central motivators of most biological beings, and that we as humans are probably unique in understanding our own mortality. So that what terrorist events do, of course, is remind us of that in frightening ways. As people, of course, we have a kind of a paradox going on wherein the primary goal of self-preservation exists in the shadow of death, and though people don't think about dying every day by any stretch, every adult is aware about the certainty of death, and it in some ways influences the social landscape. So when you think about cultural worldviews and terror management theory, and here some data has been interesting, we know that cultural beliefs are shaped by a wish for lasting legacy in the face of limited lifespan, and many cultures and religions share belief in symbolic or literal transcendence of death. So the terror of death is staved off by unity. We come together as social groups, as countries, as religious organizations, etc., and create our own worldview that brings a sense of security. And this, I think, is logical when we think about it. What happens, of course, in times of major events is that our social defenses, our psychological defenses, can be really challenged. And one thing that happens is we will cling further to our worldview and essentially collect around our group, so that defenses rise in step with an event's mortality salience, so that reminders of death increase social defensiveness. And September 11th certainly shifted human behavior in interesting ways. Now I'll go ahead and skip the next slide in the interest of time, but I'll say that, nationalism, which was an interesting response, and I think a wonderful response in many ways to September 11th, was also very much predicted by terror management theory, that nationalism effectively gathering around our worldview and our vision is in fact common. Though at times, the more salient, the more frightening the event, the more there may be generated a bias against countries, organizations, etc. And there's been data on the relationship between nationalist responses in the wake of major traumatic events for many decades now. Another interesting thing that changed after September 11th is enrollment in dating services, which I find one of the more curious but interesting responses. Enrollment in dating services tripled in the wake of September 11th. People were much more interested in coming together, in closeness of relationships. And in fact, we know from studies of terror management theory that mortality salience increases the desire for romantic intimacy. We come together. And it's, again, we're looking at social responses to major events, but they are fairly predictable. And in fact, people will change their selection criteria. What makes a good mate? Well, after an event that is this frightening and reminds one of mortality, you'll loosen up the restrictions, as they say. And that, again, is something that I think we can think about, larger scale responses. Now, we should not, this area of social psychology has its own reputation. The next slide is entitled The Scrooge Effect. It is by no means true that all reactions to events that frighten us are negative. In fact, that's not true. And mate selection may be one example, but so too charities and charitable contributions rose dramatically after September 11th, as I think all of us remember, particularly targeting the social group with which our worldview most closely allied. So domestic charities were much more beneficiaries than international charities. And again, this would be predicted in the social psychology of this area. So I'll conclude my talk today by saying that terror and terrorism are indeed important things for us to remember from the mental health perspective. that fear, including fear of death, causes reactions that can be predicted with some certainty. So some reactions like nationalistic fervor or enrollment in dating services are benign, but others, particularly when people experience that peritraumatic dissociation, that loss of sense of place, etc., after the event, are associated with significant pathology, and our job is to screen for that, to track for that, and to apply the best known interventions that we can, and work on the prevention science. Understand as we move forward, how do we prevent, after a large-scale traumatic event, people having significant mental health problems? The answer is we don't know at this time, but we have at least the screening and tracking approach to do well. So that's it. Thanks very much to everyone, and I look forward to fielding some questions.
Thank you, Doctor, and I'm sure we'll have some questions. Quick reminder, folks, if you have a question or comment, please feel free to call the 800 number you see on your screen. We'd a lot rather you ask the questions than I or Dr. Betts. So please use the 800 number now and talk to Dr. Morris live on the air. Dr. Metz, any questions? I know you didn't go out looking for a dating service since you're a happily married man after 9/11, but I'm sure you have some questions for the doctor.
Actually, I have two. One minor question. With relatives in New Orleans, I have an understanding of what lagniappe is, but I expect there are many people out there that have never heard that term before.
Sure.
Perhaps you could define it. The other question is more of an epidemiologic question, and it concerns risk factors of post-traumatic stress disorder. You suggested that younger age may be one of these, but you were also talking about depression and say alcohol consumption as effects of this, and I wonder if they could also be risk factors.
Sure. So the first question is the easy one. Lagniappe means a little something extra, so I thought I would take us away from the PTSD and give you a little something extra on the social psychology responses. As we in Louisiana, we're so full of heart and gift, Dr. Metz, that we always give something extra. In fact, your question with regard to predictors of PTSD is an important one. And I think the data would suggest that these comorbid conditions may precede PTSD and may also follow it. So they're both predictors of and associated with along the natural course of the disorder. One of the interesting areas for us to continue in the research is on the genetic substrate of mental health problems. I showed you that slide that a family history of mental health issues predicts those who after a traumatic event will go on to get PTSD. That family history may include substance abuse, may include mood disorders, may include anxiety disorders. So you're absolutely right. There's predictors and also secondary conditions that follow.
Okay. I might point out at one time we had a lagniappe hotel here in Montgomery.
Is that right?
But it finally went bust because nobody could pronounce it to start with.
Yeah.
You don't know what you're looking at.
Yeah, that's a problem.
And when you call information, nobody could give you the spelling on it. All right, to get serious about it. I think after 9/11, all of us experienced some post-traumatic stress.
Yeah.
We all felt it for several weeks.
Right.
At what point do you say this is going to cure itself?
Yeah.
Or at what point do you say, I need professional help?
Yeah. And it's a good question, Mac, and I wish I could say there's a firm answer. I'll tell you what the books say. That is, the diagnostic manual in psychiatry says that the symptoms have to persist beyond 4 weeks' time and be limiting. That is, change your life significantly so that you're impaired at work, social relationships, etc. So if it's beyond 4 weeks and that you're experiencing impairment from the symptoms, then you're going to fall into that diagnostic bin and you're going to be a candidate for intervention. Now, you may ask, well, where does 4 weeks come from? And though those of us in psychiatry don't like to admit this too often, it comes mostly from the air, which is to say it's a general rule. The data on why 4 weeks and not 5 weeks is not particularly solid, but it's a decision about the committee who look at these problems that probably 4 weeks of some re-experiencing, nightmares, some avoidance of reminders of the event, etc., would not get you into the post-traumatic stress disorder category.
Okay. I might point out that on 9/11, we happened to be in this exact studio getting ready for a program.
Is that right?
We saw the satellite feed coming down,
Yeah.
and we thought it was just a building fire to begin with until we saw the second plane hit.
Yeah.
And then all of us were in sort of a state of shock here in the studio. What should we do? And unfortunately, we had a program. We'd flown people in from all over the country, so we had to go on with the program and give updates during the program. But that was a stressful time for all of us.
Yep.
The panel of experts who had flown in from East Coast to West Coast in the studio and wanting word on what was going on.
Yep.
And we were all under a load of stress.
Yep.
That stress continued, I think, for most Americans as we saw American flags pop up on cars. We've never seen such patriotism as we saw the first few weeks. But I think in advertising, an agency will look at 13-week cycles. You tend to forget after 13 weeks. So they run in 13-week flights, or they used to when I was in broadcasting. Is that normal to feel such grasp need to do something the first few days of it and then have it wane?
Yeah, absolutely. It is normal. And in fact, all of us experience that acute sense of stress, confusion, anger. All of those feelings were absolutely typical. I think where things get beyond typical first is in the peritraumatic dissociation that we've talked about, where you're literally losing sense of place and time. You can't be pulled away from the television screen. Someone's talking to you, you don't hear them. That level, which would be uncommon from such a distance as Montgomery to New York, but much more common in the Wall Street area, where you're literally experiencing these things before your eyes. When there's that level of immediate reaction, that's a fairly good predictor that that person's at significant risk to go on and have problems later on. Now, it's by no means they've got pathology. It's just a predictor, but probably the best one we have. The cycle of sort of the larger responses is interesting, and I think the patriotic response was predictable, and I think for those of us in public health, it's sort of nice to know that there's some things that we can understand about the larger population-wide response and expect. To me, the dating service thing is interesting.
Very much so.
Yeah, and when you think about it, and it certainly does make sense, again, from this wider perspective on how people in relationships are bound to one another. So the flags come up saying, hey, we're in this together, and we're going to be okay. And I think that's a response to diminish the impact of this terrible event. So too, looking for close personal relationships, clearly a response we might predict.
I don't think that's unusual at all, and I say that only from the experience after 9/11 here. Sure. But we noticed outside of our windows when we got out of the program we were in, the streets were practically empty, and this is because the media was giving instant live coverage to everything we'd been getting bits and pieces here in the studio on. And I felt like I needed to watch television. I wanted to see every minute of every coverage I could get, but I didn't want to do it alone. I wanted someone with me, and fortunately had someone. So I can understand the dating service going up, not wanting to be alone. That's not unusual, I don't think.
I think you're absolutely right. And again, for those of us interested in this, it may suggest some things, again, getting people shelter and support and connection without necessarily asking them to relive their experiences, wherein I think we may do some harm, interestingly enough. And I think that because the data tells us that. I think there's this middle ground of bringing people together. They'll naturally do this. The streets were empty because families were there with one another. The telephone lines were jammed, of course, as it turns out, both checking on others but really wanting to connect. And I think that those are predictable and important responses to understand.
Okay. Just have a couple more things I'm going to ask you about. Folks,
Sure.
we'd like for you to call and ask questions concerning today's topic. I have enough questions to fill the time with no problem, I can tell you. But we'd a whole lot rather hear from you. So give us a call at the 800 number, ask your questions. I'll make your comments to Dr. Boris. Doctor, what type of interventions are we seeing in New York still? I can't imagine being there and being exposed to that damage for so long
Yeah.
that I had to work in the neighborhood.
Yeah.
Here, where we've seen things ease up since we've had more attacks, it's still got to be very traumatic for the folks in New York
Sure.
who go by that site every day.
Yeah.
So what type of help are they getting?
Well, you know, there's been a really large-scale response. That is to say, many professionals from all sorts of disciplines were there. So that the type of help was everything from just general support to some of the debriefing interventions that we talked about. And again, what's difficult in this area of science is when you have something that feels right, that you're trained to do, that you intuitively think should help, and that the data suggests it doesn't. That's always a huge challenge for us. So that some of the reports coming from September 11th were again telling us that the debriefing effort was ineffective or unhelpful in many of the circumstances. Again, providing shelter, financial support, the togetherness that happened here in Montgomery and New York and everywhere, those natural reactions were impressive and important. I think you're right, though, when you're there and you're in Lower Manhattan, for instance, remember that one of the symptoms of PTSD is avoidance of the stimuli, and you can't avoid it because that's where you work, and re-experiencing, that is, reminders, so that going on the same subway ride for those people who were most affected toward the same stop is going to bring them a lot of anxiety. And it's really identifying those folks and getting them the higher level intervention that they need 4 weeks or more after the event. That's what we need to be focusing on. And I know that that's what the response in New York has been in the aftermath.
Okay. Speaking of up that way, Atlantic City, New Jersey, one of my favorite towns I visited the past few years. Go ahead, Atlantic City. What's your question, please?
Well, here's the question. I would like to know if you have any information on overall church attendance since the 911 event, and if you see that as a coping mechanism for this type of disorder. And the second point is, if you could put that website again back up on the screen, we would appreciate it.
Okay. You might turn your television down when you call, and the reason being you're going to hear yourself come back about a minute or a second and a half after you say a word. It's like a speaker at a baseball field or a football field. Go ahead, Doctor, your response.
Got a terrific question about religious participation, and absolutely it went up. And in the very same way that flags came out and dating services were inundated, people came around churches, again, existing organizations, and that community network that exists is really very powerful in helping people manage the acute symptoms of stress. Absolutely. And religious participation rocketed up really across the country. And I know that it's not in my control to put the website up, but the guys in the control room.
We're ready with it
they'll
right
do
now,
it.
Doctor. We can go to the website, and we'll leave that up there for a second or two so the folks in New Jersey can make a note of it, and everyone else also, the mental health crisis intake form. So we'll leave it up there for a second. That's a pretty long address there.
Yeah. We're going right to the CDC website and then pulling up what is really a survey instrument that's been carefully put together and helpful again in tracking in your community what's happening in terms of mental health issues post-event.
Okay. I'm going to show the website in just a minute for the website where you can fill out the evaluation form online. And but I want to go back to the phones quickly. We have California, who's been on hold for a while. Where in California are you viewing, please? Hello, California.
Hello.
Yes, go ahead with your question, please.
Thank you. It's Orange County. I'm wondering if there's anything that individuals can do or communities that can do proactively to prepare emotionally for the impact of such an event should it happen. Thank you for taking the question.
Thank you for calling, California. Doctor?
That's a terrific question. And again, one of the frustrating things in terms of reading the scientific literature is that there are not a lot of well-studied preventive approaches to prepare people for the mental health impacts of traumatic events. You think about it, of course, that probably makes some sense. People don't want to come to a gathering where we talk about terrorism and traumatic events. So that even in engaging people around prevention in this area, it's problematic. What I like to think about is the predictors of PTSD and Dr. Metz's question about those with substance abuse problems, etc., those who've been traumatized in the past. Those folks really could use extra support and services. So for a community to prepare, understanding who in the community is at highest risk is probably the first step. Again, a community-wide preventive approach, we just don't have at this point. And maybe someone out there in the audience could suggest some findings, but it's been tough for me to find anything well studied.
Well, thank goodness we don't have the same situation folks in the Middle East have, such as Israel, where
That's right.
terrorist attacks are a daily occurrence in
Right.
a lot of places, and certainly in Iraq and Iran. That's one thing our country's blessed with, but we've said for years we're not invulnerable to attack.
Yeah.
I don't think any of us in the public health arena expected an aircraft attack as we had. We always thought it'd be a biological warfare event. But now, I think all of us are resigned to the fact we can have another attack in this country, and we have to prepare for it in all areas, including mental health and being able to cope with it. But we're so complacent in this country when things ease back off and things are better, you can go shopping again, and the holiday season's here, and we all tend to draw back and say, no, it's not going to happen, when we know it could happen any day.
Sure.
So that's one reason I wish we could get more prepared for it, but like you say, until something else happens, we're not going to draw together. Let's go back to the phones. Thanks, New Jersey, for calling. What's your question, please? Okay, if you turn your television down, what you're doing is getting a bounce back, and then you'll be able to hear us live on air.
Yes, hello. Is there any information that you can give us on intervening with two vulnerable populations, the chronically mentally ill and children, in the aftermath of a terrorist attack?
Good question. Hang on the line, New Jersey. We'll be back with you.
Terrific question, and first thing I want to deal with is the issue of children, near and dear to my heart. And I know that one of my colleagues, Elmore Rigamer, came here to this very studio and talked about dealing with children's responses to terrorism. I'm not sure, Mac, whether that talk would still be available online, but I think probably so. When I was talking with the guys in production, I think these are available after the talk happens online. So the first thing I do with regard to children is refer you to Elmore Rigamer's online discussion of children's responses to terrorism. It's a complicated area. It would take me a long time to delve into that one question. So let me shift over a little bit to preparing the mentally ill, and I think it's a very important question. It's difficult now in that the mentally ill are not in any given area anymore. In fact, most institutions that used to house the mentally ill don't exist anymore, so that folks with chronic mental illnesses are spread throughout the population. They are certainly at risk for post-traumatic stress disorder and probably at much higher risk than the general population. We're forced, I think, at this point to engage families, and the National Alliance for the Mentally Ill is one of the most terrific family-based organizations that is nationally present, that has local chapters, and within those local chapters they educate families about assisting the mentally ill family member in many ways. And I know that that includes in how to talk them through and walk them through disaster response, etc. So I would say that the National Alliance for the Mentally Ill can give lots of good information about serving those with mental illness and helping them in PTSD.
Okay. Folks, we're going to give you a couple of seconds to get more phone calls in for Dr. Morris. We hope you'll call and ask questions. In the meantime, let me take care of just a couple of housekeeping notes. When you call, let me impress upon you, if you're watching the teleconference today on the website, you're actually hearing what we're saying about 3 or 4 seconds later than we said it, if that makes sense. So it's going to be very difficult to talk with us with your website on. If you turn it down, we'll feed you audio down the line so you can hear the answer to your question. Usually on a satellite transmission, it takes about a second delay for the signal to go from here 22,000 miles into space and back down to your receiver. In the website, it has to go to the satellite, back to our receive site, through the website, and then back down the line. So it's just a very large delay when you're watching on the web. We're glad you're watching on the web, by the way. We're very proud of our operation here in Alabama, and we hope you're getting a great benefit out of it. We're going to leave that number up there just a second for you to call, and then just a second after that, I'm going to give you the website. I want you to go online. Please do me this favor and fill out an evaluation form that's on our website. You don't have to take any paper or anything. Just fill it out online. We do like to keep track of the programs, and we have lots of folks viewing across the country today, from, as you heard, from New Jersey out to California, Texas, Florida, and on up into Minnesota. So if you would, click on the website you see for the evaluation form, and then click on evaluation form for 12/2/2003. And that'll get you into the system so you can fill it out very quickly, and it won't take just a second, and we sure would appreciate it here in Alabama. Dr. Metz, any questions you'd like answered again?
None others.
Okay.
Very interesting information, though. Appreciate it.
Well, I could talk for days, I guess, about this subject, because I think all of us were so impacted by 9/11, and we all have personal experiences. And I mentioned to you, I think all of us felt a need to go out and do something right then. I didn't feel comfortable just watching it. I wanted to do something. And at the same time, there was fear and apprehension. I don't think we'd have a terrorist attack in Montgomery, Alabama, but neither were the folks up there in Pennsylvania and Washington, the Pentagon, thinking about an attack. So it's possible. Anything's possible.
Yep.
So you feel like you had to be prepared.
Yep.
And a lot of folks I know got their guns loaded, they bought ammunition, and we didn't know what to expect. What do you do with that?
Yeah, and I think, again, understanding that those effects are going to happen in the population and that people need calm reassurance is critical. Those who are at the site of impact, those are folks we really need to get out, screen, and track to see what happens to them over time. Those who are further on out from the site of impact are going to need that basic reassurance. We're going to need to understand that these reactions are part of the way that people react to significant traumatic events. And I think you said, Mac, there's this urge to do something. There's this urge to prepare. And I think in mental health, we've got that urge, and that urge led to the development of these debriefing methodologies. And one of the problems is that the urge to do something in this particular instance, with this particular type of problem, that is chronic anxiety, by asking people to relive their experience, we may be doing something that is unhelpful. And so while we look at the population and see that many responses may happen, the mental health community has to step back for a minute and decide what the most impactful and non-harmful interventions might be.
Should we have an attack in the future as we had on 9/11? Let me back up a step here. Do you think the public health arena did enough after 9/11 to explain the anxiety that we had not studied in this country basically up until that point?
Yeah.
And what do you think we should do differently should we have another attack like that from the public health standpoint?
Well, I think the preparedness message here would be that we need to get better at screening and tracking. That instead of implementing large-scale programs to debrief people at the site of events, we ought to use those resources to back off and provide a treatment network for those people who we screen in as at high risk and follow over time. So that the message here, and this is as far as the data takes us, is first do no harm at the time, screen, track, follow, and intervene with what we know works for those who are impacted. It'll be a minority of the population, maybe 10%, but that 10% will really suffer, and we need to find those folks and give them the effective interventions. So our money's probably at this point best spent on somewhat of a delayed mental health response. And I think when I first looked into the literature, I wasn't sure that that was the way it would be, but it's pretty clear that that's the most beneficial approach at this time.
Okay. Dr. Boris, I always enjoy the programs, and I always learn a lot, and I learned a lot today. We thank you for making the visit to Montgomery.
My pleasure.
Dr. Vance, thank you for being with us in the studio today. Folks, we'll be back next month with agroterrorism?
No.
No, it's January.
January is going to be risk communication with Dr. Cavello.
Oh, okay. We changed then, didn't we? That'll teach me to ad-lib. Thank you for joining us. Hope you have a good day, and we'll see you next time on the Alabama Public Health Training Network.